Hello, my name is Cassidy Evans Windsor. I am a doctoral student at A.T. Still University, and today I'm going to talk about the findings of my applied research project, Athletic Trainers' Observation of Social Determinants of Health in the Collegiate Setting. The CDC defines social determinants of health as the conditions in which people are born, live, learn, work, play, worship, and age that affect an individual's overall health related quality of life. The WHO similarly defines them as the non medical factors that influence health outcomes. They are conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. Social determinants of health can be divided into 5 domains: economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. Economic stability includes work stability and the ability to afford items that contribute to overall health, such as healthy food, housing, and quality healthcare. For example, when an individual has a job that pays enough to keep a family above the poverty line, they often have more opportunities for safe housing, healthy food, and private health insurance. All of these things can lead to less stress and better lifestyle habits that develop to better health. Education access and quality includes access to good schools of all levels, which can lead to healthier and longer lives, as well as decreased levels of stress. Access to education increases an individual's likelihood of obtaining higher paying jobs, access to scholarships, and better economic stability. Healthcare access and quality include access to insurance, medications, preventative screenings, and access to overall healthcare. When access to healthcare is available, preventative care can be administered instead of utilizing a reactive approach. When prevention is successful, the cost and financial, emotional, and physical burdens are often reduced. Neighborhood and built environments involve rates of violence within a neighborhood, unsafe air or water, or lack of access to, and other health risks such as structural integrity and pest control. When access to basic needs are limited, illness and poor health may follow. Historically, underrepresented and lower income groups more often live in poorer conditions, making optimal health difficult to obtain. Social and community context includes relationships had at home, work, and within the community that can affect overall health related quality of life. Relationships can have both negative and positive influences on health. For example, if an individual has a strong support group, they are more likely to thrive in an environment than those that lack a support network. Research suggests that social determinants of health are more influential when determining patient health outcomes than the quality of the health care received. Addressing social determinants of health in all populations can improve patient outcomes, leading to better patient-centered care. Athletic trainers are in a unique position within the athletic healthcare system to assess social determinants of health. Often, ATs serve as the only healthcare provider an athlete interacts with regularly. Because of the settings many ATs work in, it is likely that they may be the first to observe social determinants of health and how they impact overall health in their patients. Therefore, the purpose of this study was to explore athletic trainers' observations of social determinants of health at the point of care in the collegiate and university settings. This study was completed using an observational card study design. Card studies are designed to collect clinician observations at the point of care without altering or changing the interaction between the clinician and the patient or the care itself. This study design allowed the research team to gain insight into what social determinants of health athletic trainers at the collegiate level are observing at the point of care. A sample of ATs employed in the collegiate and university settings were recruited to participate through criterion-based convenience sampling. An individual was considered eligible to participate if they were currently providing athletic training services in the collegiate setting. Packets were sent to all participants that included data collection instructions, 30 collection cards, and a definition sheet for all the social determinants of health listed on the cards. A card was used to capture social determinants of health during meaningful patient encounters. A meaningful patient encounter was defined as an interaction that occurs through verbal communication and or physical examination. An example of a meaningful encounter is when a patient receives passive stretching after practice and the athletic trainer engages in conversation about how the patient felt throughout that practice, opposed to wrapping an ice bag on the athlete without any clinical relevant discussion. Data was collected every month for almost a year. Each participant collected data for 1 to 2 weeks. Due to the observational nature of this study, only descriptive statistics were calculated, including which social determinants of health were most observed, which social determinants of health had the most negative impact on patient health, and frequency to which action was taken by the athletic trainer. Distress scores were also collected based on the Distressed Community Index, or DCI, of the site's zip code. A DCI combines 7 different metrics using the latest Census Bureau data to determine the levels of economic well-being within a community. These scores were used to track diversity across collection sites. Each site was placed into one of 5 categories: prosperous, comfortable, mid-tier, at-risk, or distressed. 324 cards were collected from 17 different participants across 14 different colleges and universities. There were 472 total social determinants of health observed. Most participants were female, white, and had earned a master's degree. 2 participants did not complete demographic information for us to report. The pie chart on this slide indicates that there were 472 social determinants of health observed, with 36.8, or the green area, perceived to have a negative impact on the patient's health. The top 3 social determinants of health observed were access to social media or emerging technologies, academic stressors, and behavioral health issues. Behavioral health issues, transportation issues, and academic stressors were the top 3 social determinants of health that had a negative impact on overall patient well-being. Despite not being observed as often as other social determinants of health, athletic trainers reported that 83.3% of the time when insufficient or lack of health insurance was present, and 66.7% of the time food insecurity was observed, there were perceived negative impacts on health. Behavioral health issues were reported to have a perceived negative impact on health approximately 65% of the time in patients when that specific social determinant of health was observed. 1 college and university fell within the prosperous distress group, 2 fell within the comfortable group, 4 were mid-tier, 6 were at risk, and 3 were distressed. Most patient interactions occurred in schools that were in the at-risk category, followed by the mid-tier and distressed categories respectively. It appeared that social determinants of health had similar rates of perceived negative influence across most groups. Of the 472 social determinants of health observed, ATs reported taking action on 32% of them. The most common social determinants of health where actions were taken were behavioral health, academic stressors, and lack of health literacy. The most common actions taken were providing patient education and referral to outside providers. Behavioral health and academic stressors were 2 of the most observed social determinants of health that had a perceived negative impact on patient health. Behavioral health was also perceived to have negative effects on overall health in 65% of patients. These findings were not particularly surprising, as previous studies have found consistently that one of the most common causes of mental distress in collegiate athletes is academics. The National Collegiate Athletic Association developed a mental health and athlete wellness task force, which released a mental health best practices consensus document in 2016, which was later revised in 2020. This document is guiding coaches and healthcare providers in navigating mental health issues in collegiate athletes. This document also outlines the importance of mental health screening in pre-participation physicals, the need for emergency action plans for mental health emergencies, and identify appropriate clinical staff to handle such situations. It is important to note that while often first responders for behavioral health conditions, athletic trainers are not considered an appropriate healthcare provider to handle a behavioral health condition on their own. These findings suggest that collegiate athletic trainers should be prepared with behavioral health emergency action plans and policies and procedures to handle behavioral health conditions and emergencies. Insufficient or lack of health insurance had the most perceived negative influence on overall health when compared to total number of observations compared to all other social determinants of health observed. The cost of healthcare in the United States continues to grow 4 to 6% each year, costing roughly $3.8 trillion, nearly twice that of other developed countries, and can be a major source of stress. The collegiate setting is unique in the sense that some institutions cover all additional costs of healthcare for student athletes. However, the financial amount that a collegiate setting covers for external services varies greatly between universities and was not collected within our study. Even though a college may cover all healthcare costs for student athletes, athletic trainers need to be aware of the cost of healthcare and how they can help reduce costs for patients through their clinical decisions, especially for those that do not have sufficient insurance. This is particularly important as athletic trainers often serve as the only healthcare provider within a community and may be faced with handling untreated health conditions due to lack of insurance or quality healthcare. Even though homelessness and poor or unstable living conditions were minimally observed, they were mostly observed at the universities in the distressed and at-risk distress score categories. Similar findings were discovered for food insecurity. While we did not track patient demographics, this preliminarily aligns with previous research that athletes from lower income areas, especially if they identify as a historically underrepresented individual, are particularly at risk for negative influence from social determinants of health. Lower socioeconomic status can lead to inadequate living arrangements and lack of accessibility to transportation and healthy food. This can hinder tissue healing and growth, as well as magnify other social determinants of health and stressors. Athletic trainers working at schools in distressed or at-risk communities should be particularly aware of social determinants of health and how they present in underrepresented populations, and how their background prior to attending college or university may influence their overall health-related quality of life and healthcare decisions. Educational limitations and neighborhood safety were not observed by athletic trainers in this sample. These social determinants of health were not easily observed without further questioning or without an established relationship. Social determinants of health are often intertwined together. Therefore, it is possible that the social determinants of health not observed within this study may be presenting as other observed social determinants of health. For example, while it is possible for someone to have access to healthy food while not having economic stability, it's not usually likely. Even though educational limitations and neighborhood safety were not observed within this study, athletic trainers should not assume that a student athlete has not experienced these social determinants of health prior to attending university, or that they are not currently experiencing them. Alternatively, athletic trainers should aim to measure social determinants of health through regular use of patient-reported outcome measures, which could lead to deeper patient conversations and understanding, potentially highlighting some of these more difficult to observe factors. Better observations, assessments, and considerations of social determinants of health in clinical care can lead to more health equity within athletic training practice and better patient outcomes. Athletic trainers are not going to be able to mediate or solve all of the complicated issues leading to health equity, but they should be prepared to work with patients that have felt the effects or results of health inequity through observing social determinants of health. Overall, social determinants are more important to address to provide patient-centered care than the actual care given itself. Collegiate athletic trainers are observing social determinants of health within their clinical practice, and they need to be prepared to help address them when needed. It is particularly important that collegiate ATs are prepared to address behavioral health issues and academic stressors, as these were the most commonly observed social determinants of health in this study. This includes having mental health emergency action plans and policies and procedures that include resources that individuals can help student athletes dealing with these struggles. Athletic trainers should consider the integration of tools such as patient-reported outcome measures and disablement models to better access and understand how various social determinants of health may be influencing their patients' overall health and well-being. While this study supports athletic trainers' ability to observe social determinants of health in their clinical practice, future research should focus on identifying how to best assess social determinants of health from the patient perspective and confirm athletic trainers' observation of social determinants of health within their clinical practice. Thank you for listening to this presentation. If you have any questions, please feel free to email me at sa200818@atsu.edu.